Hello, everyone. We'll let people continue to trickle in, and then we'll go ahead and get started in just a moment. Thanks for being with us today. All right, I see the numbers slowly climbing. It's 1 p.m. Eastern time. We'll give it, again, just another 30 seconds or a minute or so. I know it takes a moment for people to be able to join, and then we'll go ahead and get started. I'm excited to share we had several hundred registrants, which is fantastic. Of course, we know not everyone can join events they register for, so of course this will be made available in an archived version after the fact. But why not dive in? So welcome. I'm Jessica Solomon Fisher, Vice President for Strategic Initiatives at the Public Health Accreditation Board and Public Health National Center for Innovations. And here we are today to talk about staffing up, strengthening the public health workforce for the next generation. I'm excited to be joined by people that you see on the screen here. You are in great hands. I'm not going to read their bios. I'll ask them to introduce themselves when we get to the panel portion, but rest assured, we've pulled the best and the brightest to talk today about public health workforce. And I'll mention that we are also joined on the line by JP Leiter, who is one of the brains behind this project. On the next slide, just a moment to set the stage for us. I'm going to really run through the nuts and bolts, but really are going to leave most of the kind of why this is important to the panel discussion. So I'm not going to provide a lot of context here. You're all living the context. I think you know why this is important, and we look forward to discussing it with you shortly. But for now, I really just want to talk about the what of what we're doing. And before we do that, just a way to make sure you're all here with us, let's just do a quick poll. So for those of you in health departments, do you know how many staff your health department needs? Yes, no, or unsure? All right, let's see what people said. Unsure. Well, great. Then we hope that the tool that we're going to talk about can help you. So again, we all know, what's going on in governmental public health. We know there's been a 15% decrease in staffing in health departments due to a lack of investment, consistently over the years. We know that compounding that is the current exodus of staff at all levels, state, local, tribal, territorial health departments since the start of the COVID-19 pandemic. And so we partnered with the Beaumont Foundation to develop an estimate to really understand the need for implementing core public health, and then to develop a tool that could help health departments use data to plan what FTEs they need. So the first thing we'll talk about is work that's been completed, which is the staffing estimates needed to implement the foundational public health services. You can see that graphic on the screen. We're actually in the midst of revising it slightly, so we'll have a new, better looking graphic in the next couple of weeks and made just a few tweaks to the model. But the point here is that this is really at the core of governmental public health practice. It's not every single thing that health departments do, but it's the infrastructure or those capabilities that are important that then hold up the kind of core program areas that health departments do. And that's what we're talking about today when we think about this estimate. It's that core work does not account for those expanded services or everything else that health departments do that are specific to their community's needs. So that's a crash course in the foundational public health services for you. Much more we could say about that another day. The second part of this work then is to create a public health workforce calculator that will allow health departments to determine the number and type of staff they need to provide the foundational public health services. So about half of you said you were unsure how many you need. We hope the calculator will help, and we expect that to be available this summer. We're working on development literally as we speak. On the next slide, just wanted to call out the project partners for this. So if we go to the next slide, we've got the Beaumont Foundation and PHNCI at PHAB, which I've already mentioned. The quantitative and qualitative research team and experts, those have been led by JP Leiter, who's at the University of Minnesota. We also have in the second part, the calculator part of the work, the Centers for Disease Control and Prevention. We have the Center for State, Tribal, Local, and Territorial Support as a partner. And then the University of Washington Chart of Accounts team doing the data collection for the calculator. So those are our two newest partners. And just to note that all along the way, we've been provided by guidance from a steering committee, from a research advisory committee, as well as qualitative interviews and focus groups to inform the work. So again, we're not spending a lot of time going into these details. We do have a full methodological report on how the estimate was developed that we're happy to make available, but really just wanted to let you know kind of who's been involved to date and who they represent. So if we go to the next slide, a little bit more about what we did. We wanted to estimate the number of FTEs needed in health departments to perform the FPHS. As I said, not everything that health departments do, excuse me, but the core foundational work that every jurisdiction ought to be provided by their governmental public health system. And we were to generate totals and ratios based on the number of staff needed per 100,000 people. And importantly, the recommendations were really intended to provide an infrastructure that you can surge on during a crisis, but are not inclusive of that surge. So the number you'll see is not inclusive of how you would respond, for example, to the COVID-19 pandemic. We did do focus groups, key informant interviews, as I mentioned, and I just wanted to share a quote with you that I think gives a little bit of flavor to the value of this work, which again, we'll talk about with the panel. And that quote was, "To me, a calculator, formulas, standards give us the foundation for data-driven decisions. You need data to go to a legislator. You need data to support why laws need to change. You need data to convey to your community why the public health tax may need to increase. So calculators, formulas, those types of things provide us with another mechanism for providing the data we need to communicate why it is we're doing what we're doing." And I just think that really gives us a nice basis for the work that we're doing today. On the next slide, a bit more about the methods and a shout out of thanks to our partners who did this work, but of course the ASTO and HO profiles, the Public Health Workforce Interest and Needs Survey, which I believe is in the field right now, and I encourage everyone to complete. Financial and FTE information from around 170 local health departments in the 21st century learning community states, a few of them, so Oregon, Washington, Oregon, and Colorado. So we got data from 3 state health departments and 170 of their locals to help build the estimate. And on the next slide, just one more thought on the methods, which was, again, to determine how many FTEs. There were several modeling approaches considered by JP and his team. And thanks, JP, for putting in the chat box the rest of your team members. Looking at rurality, service mix, measures of health and social need. But the best performing model was actually relatively straightforward. It fit a power curve to the log of FTEs and population size by FPHS. So then FTEs were calculated both in terms of current from FY 2018 data, so current achievement against the foundational capabilities. If we ask the health department, how do you achieve? Do you fully achieve these? Do you partially achieve them? It was the current state of things. And then thinking about what would it take to fully implement the foundational capabilities in areas. So if a health department thinks it's at 50%, how many staff does that take and what does it cost? And if they were to get to 100%, how many staff would that take and what would the cost be? So that's the kind of data that we were collecting from these states that have done a great deal of work in that area. And without further ado, what were the results? Hopefully you've all seen this. These came out last summer, but that state and local governmental public health agencies need an 80% increase in workforce to provide minimum public health services to the nation. That's 54,000 FTEs at the local level and 26,000 FTEs at the state level. Again, not for everything, only to do the foundational public health services or that core work, and not even accounting for a pandemic. So if you want to put in the chat box, how does this feel to you? Does this seem right? Does this seem small? Does this seem high? Was this number a surprise? Was this number something you expected? Just curious about the number. It's equivalent to 80,000 FTEs. It's a lot, and I'm sure you're all feeling it at the local level. On the next slide is just another way of looking at these numbers for those who are more visual learners. Again, 80%, the breakdown between what state and local health departments currently have and what they need. And then on the next slide, getting to that population level data. So you can look at if you're in a local health department, if you're in a state health department, what the kind of needs and what the gap is there. And I'm going to leave this up for a moment so you can kind of find yourself in here and think about that for just a moment. Again, the current implementation versus additional FTEs needed to do more of those foundational capabilities. All right, and on the next slide, again, another way of looking at the data, which is broken down by some of those foundational capabilities. So at the top, looking at FTEs needed for assessment and all hazards preparedness and response. And then on the bottom, the foundational areas are those kind of key program areas, calculating at the end up to that 80,000, but what's needed really in each area. And again, wondering how this resonates. And I see the chat box is active, that's great. Okay, so these were the estimates. Let's move now to the public health workforce calculator. So again, the goal here is really to develop a tool that health departments can use to estimate their own workforce needs to provide the FPHS within their current context. So it's a resource for health departments to use in planning, can support advancing equity so that health departments have the adequate staff they need, can be used to justify why you need more funding for additional staff, et cetera. And this work is going on right now. We're working to collect more data of the kind that I mentioned we collected before, but even more data from other states to round out the sample that we have. The states we have all are, decentralized states and have other kind of things in common. So we were looking to now get just different kinds of states to do better data collection and then build the calculator, which we will be launching this summer. So really excited about that. I know I've gone through this really quickly. If we go to the next slide, that'll just give you the website, our Twitter accounts, et cetera. But really want to move now to the presentation or the panel part of this discussion. As I said, I was going to run through pretty quickly the nuts and bolts just to make sure you all know that the estimate exists. Again, it's been out for a while. There's a full report. There's an infographic. So there are tools that you can use and more information available to you to use in your own work. And then the calculator will be available. So this is really a tease that's coming soon, and we're really excited for that. But now is the fun stuff. So we have this esteemed panel of colleagues with us today. Again, I'll ask them each to introduce themselves as we go, and we're just going to have a conversation. So please keep the chat box coming. I will certainly monitor that in addition to the prepared questions that we have, and we'd really just like this to be a conversation for today. So my first question will be for all of you, and we'll just go around. And Megan, I'm going to start with you, which is if you could give us the 30-second introduction of kind of who you are, and then also why you have an interest or focus on workforce, what this means to you.
Well, thanks, Jessica, and thanks everyone for having me here. I'm excited to have this conversation. My name is Megan McClare. My pronouns are she, her. I'm the Chief Deputy Director of LA County Department of Public Health. And in that capacity, I oversee the whole operation side of the house. So from personnel issues to contracting to training and development. And I also oversee our Center for Health Equity in our Office of Communications and Public Affairs. And really the goal of my work is to be able to ensure that all of our systems and operations within our department really serve our racial justice and health equity principles. And part of why I'm really interested in staffing up in this conversation is that one of my first mandates once I started here was to really develop ways to make our hiring process more streamlined and really responsive to the needs of the department. So before the pandemic, this was an active issue, especially during the pandemic. And as we continue beyond this, how do we sustain an infrastructure that makes us do our meaningful work the best?
Thanks, Megan, and welcome. Nafisa, same question.
Oh, thank you. Thank you. Good afternoon, everybody. I'm Nafisa Bonye. I'm the Blackhawk County Public Health Director here in Iowa. We're located in the northeastern part of Iowa. It's exciting to be here. The reason why I've been interested in this is because, one of the things, as Megan mentioned, is that workforce development and sustainability is very critical in how we provide the services that we do to our community. In addition to that, I think oftentimes, the numbers or the FTEs that we come up with, needs to be data driven. And right now, this is such a critical time for that to happen as well. So this is really important. And thirdly, I think it's also important that we recognize that in order to really achieve health equity, we have to think about our workforce and the key positions that we need, our recruitment, streamlining our recruitment, and ensuring also that our populations or our workforce is reflective of the populations that we serve. And so this is why I've had a huge interest in workforce development and capacity building. Thank you.
Great, thanks for being here. Brian, over to you.
Yeah, I'm Brian Castrucci. I'm the president and CEO of the Beaumont Foundation. And before that, spent 10 years in practice at the state and local level. I'm interested in this because this is what we are, right? We are our people. We don't have fancy technologies. We don't have machines. We are us. And if we don't have the right number of people in our health departments, we cannot be expected to do the work that the community expects us to do. You know, we are surging on existing staff shortages. And so we were behind the 8 ball before this pandemic ever began. And in some ways, this is a conversation, and I'm watching the chat with all the questions. This is a conversation that has been long overdue in our practice. You know, we should know these answers. We should have known these answers. And so that's why this is exciting, because we need to build an advocacy base. So when someone asks us, how many staff do you need and what should they be? We have those answers.
Thanks, Brian. And Jeanette.
Hi, everyone. Dr. Jeanette Kowalik, she, her, hers, president of Jail Solutions Consulting Services, and also contributing faculty at Baylor University. And I'm reflecting on my career. This is my 20th anniversary in public health. And I completed my dissertation research in public health workforce and looking at job satisfaction as a way to predict retention of the public health workforce. And obviously we're in this pandemic, many people are leaving. I left, I was the health commissioner of the city of Milwaukee from 2018 to 2020. Milwaukee is my hometown, so knowing the city very well and the challenges of the Milwaukee Health Department drew me back home for that position. But being sorely underfunded truly created a number of issues for me to even be successful in the role. I recently did an opinion piece for the Journal of Public Health, AJPH, about is it noble to be a health officer still in this day and age? And honestly, it is. But I mean, if there's not going to be adequate investment over time in public health, it's going to be very difficult to be successful and to prove why there needs to be continued funding in public health. So just, reflecting on the research that I did years ago and looking at where we're at right now, where this influx of funding into health departments because of the pandemic as a patch, there just has to be sustained funding to continue the work. And then lastly, just really uplifting equity and hiring practices and making health departments a safe place for people such as myself as a Black bisexual woman being in a health department, and just really doing better by listening to the community and doing things differently instead of being married to the old way of doing things. Thank you.
Thank you. I'm going to take us off course just a little bit because there are great questions coming in the chat. So first, just a quick methodological one, and JP, I'll punt this one to you. And JP's not able to be on camera with us today, but as I said, he's here. The question is about the data that was collected for the estimates from the 21st century states and whether at baseline these states have better public health funding than others, and does this impact our understanding of how many more FTEs are needed? So I know the anecdotal answer to the question, but I'm going to ask you to speak a little bit more of the methodology of that and the kind of validity of that estimate, if you would.
Sure. So we did use 4 states, and in looking at which of these states would be representative or kind of transferable or translatable to the broader U.S. Forgive me, there was a bit of noise. What would be translatable? We looked at the distribution of spending in these agencies, compared it to the nation overall, looked by varying characteristics like centralization, urbanicity, and rurality. And we found that these folks were middle of the road, though there were some locals among the 168 that were a bit higher, a number that were quite a bit lower. I think one of the strengths of the states that we had is we have a lot of rural and smaller jurisdictions, which constitute the majority of health departments in the country. So I think that there is always more we can do to make these health departments generalizable. That's why we're collecting more data for our second phase. But I do feel good about how useful or generalizable it is to the rest of the country.
Perfect, thank you. And my next question was going to be for Brian, and still is going to be for Brian, but it's a little bit different because, Brian, I think you answered part of my question when you introduced yourself, which was really about the importance of staffing up in today's context. So instead, I'll ask you to talk about when we look at the gap, the delta, right? How many staff or FTEs we need, and we think about hiring as a challenge for governmental public health departments. The question that came in was, what is the recommendation for hiring on such a large scale? New FTEs, training. This in and of itself will take a lot of existing staff, time, resources. And we think, of course, also about the federal funds that have come out for staffing in public health. So just any thoughts you have on hiring challenges in health departments?
Yeah, I mean, there are so many thoughts. I mean, I'll always take what Mike Frazier says, and we shouldn't make a government problem a public health problem. Our hiring issues are about government. Our hiring issue, every time we get a fellow at Beaumont, 6 months after they start, the health department they applied to a year ago calls them and says, hey, would you like to come in for an interview? This is not about, this estimate in this report is not a destination, right? So I did not find these data in a burning bush. They were not carved into stone tablets. They are part of a journey that we all have to be on around modernizing how we understand our public health system. And the fact that we're in 2022 and just now being able to say, here's an estimate of how many people we need, right? We have a whole world of air traffic control that somehow manages to run in different areas, in different capacities, but we have a good sense of that air traffic control system protecting this nation. We don't have that in public health. We have different staff sizes. We don't know how many folks we need for what we're doing. These can't be, we have all too often just answered when legislators have asked us, how many staff do you need? We need more. Well, how many more? Well, probably more than you'd even fund us for, so we don't even have the number. Those are insufficient answers to legislators, to the community. We need to be very clear. When people ask us, how much money do you need? How much staff do you need? We have to have answers to this. We need answers at the local level, the state level, and the federal level. And in the absence of those answers, of those data, then we get often lost in the shuffle. And there's great questions in the chat about how we will actually build our public health system after this transitional money is gone. That's a really good question. It's not clear that we're even going to be able to hire people on money that is not permanent. I mean, those of us who've worked in governmental public health know it's really challenging to hire full-time permanent staff on short-term soft money. But these are actually the things that we have to talk about, right? We have a moment in time right now where we can say, this is, you've all felt the pain point now. And if we continue to go the way that we're going, the next pandemic will be worse. But we have to have very clear answers. How many epidemiologists does a health department need? And the fact that no one can answer that question for me at this moment in 2022 is a deficiency in the work that we've all done in advocacy for our field. We need a much firmer advocacy base from which we can work from. What are we funding? And we've done it before. Unified chart of accounts, different initiatives that we've tried to bring us together so that we have this information for advocacy. We've often, these efforts have not done as well as we'd like. Us trying to get data to do this work has been challenging, but we're going to have to come together and advocate for ourselves, because when you look at like a flight attendants union or the police union, they're not asking these questions. They know exactly how many flight attendants you need to run a flight. They know exactly how many police they need to police a neighborhood, but we don't have those answers. That puts us at a deficit.
Thanks, Brian. That was great. And let me turn to Megan first, and then Nafisa to share your thoughts on the same thing, being in the position to have to make these hires or to have staffing shortages yourselves.
Yeah, I think it's worth noting that hiring at this scale somewhat happened as a nature of having to respond to the pandemic. For our department, more than 75% of our workforce had to shift into incident command to support just the operational impacts. With new funding, we hired upwards of 2,000 contractors and temporary staff to support our operations. And, so I mean, we were making really shifts and being really creative about that work. I mean, to the point of historical divestment as well. I mean, where, every year we're dealing with cuts, we're losing funding, and we're only 17% supported by our local county government. The rest is all grants or fees that have mandated and additional responsibilities. And so it's not like we have all of these flexible dollars to be able to shift that work. And so, I mean, I think we've really been able to respond to that time. And I think we've been able to also note, like, this is where we've had these key deficiencies. Fortunately, in California, we have a public health infrastructure bill that's going to be able to help us sustain this work, to think through how we sustain some of these operations, in addition to some of the federal funding that's come in the short term to help us, maintain what we've identified as like a need for realignment. But I think it presents a unique opportunity because I think, public health is an entity that I would argue probably has the most broadest scope of work to complete. And in comparison to our 35 sister departments that have to respond to emergencies. So when we think of like fire, sheriff, who can really articulate that information, we have to do the same work. And so in addition to the fact that we had to shift to 7-day-a-week operations that we didn't have before. So I think that there's things that we can quantify as part of this response. And I think that we can couple it with this tool to state that obviously these are unprecedented times, but we had to operate on a disparate infrastructure. And where did these shifts have to happen? How did this impact our regular operations? And then how do we make sure that when this next pandemic comes, because unfortunately, I don't think we've learned all the lessons that we need to avoid a future one. But when this happens again, how are we positioned to be able to do this without the hardships that it created over other parts of our operation?
Thanks, Megan. And obviously on the large scale, being in LA County. So let's go back to the Midwest for Nafisa and what this looks like in Black Hawk County.
Wow. So I'll share a little bit about what happened to us. About 5.5 years ago, I was hired to restructure the department. It was a department that was predominantly focused on direct care services. And so we had 120 FTEs, and it was considered to be one of the largest in Iowa. And so that was, for people that was exciting, but we have an FQHC, we have a healthcare system. And so my mind was like, why are we focused so much on direct care services when that's not really the lane of public health? So we restructured, and through that restructure, there were layoffs that occurred, and we lost about 50% of our staff. But I remember telling our elected officials that we are going to have to rebuild. Right. So the restructuring was necessary, but now we're going to have to rebuild and focus on the essential services of public health. So through the layoff process, the health department was receiving kudos. They were excited that we were lean. But unfortunately, when we started rebuilding, there were so many questions like, why do you need this position? And really wanted us to stay at a much lower FTE than we had anticipated. And so this, to me, this data is really important. This report is complementary because, as you stated, Jessica, it provides us a planning tool, but also it allows me to be able to show that there was a formula that was created for local health departments. And so for us now, it's more about educating our elected officials and understanding the formula behind this number, the critical positions that we need. And I think that you start to get more buy-in little by little. It's not easy, but we are right now, we have about 56 FTEs. And so I can show them this report and say, okay, we're getting closer to the number that we need. And here are the key positions that we've identified that are needed in our program. And so I use it as a planning tool. I use it as an advocacy tool. And I use it also as an education tool, because I think some of the things that really are missing is how do we communicate this information in people that are not familiar with what we do? We've been in an invisible field. We came to light because of the pandemic, but yet people still don't understand the services that we provide outside of COVID-19. And so I think that's something that's so important for us to continue to do while showing the data.
Thank you. So a few threads. Oh, go ahead, Brian.
Because a lot of what Nafisa said, I think, is important. So she talked about having to restructure and rebuild the health department and issues of whether the health department was lean or not. These are all words that really need to be grounded somewhere, right? These should not be a point of view. And so we're building our health departments like it's a choose your own adventure book. You should have had standards that we were looking towards that helped you understand. If you have this many people, here's the complement of services that you need. We failed partly in our pandemic response because we didn't even have many health departments. They're not LA. LA is a super well-resourced health department, but in other health departments, they didn't have any communication staff. They didn't have any PIOs. And yet all of a sudden, you're in front of the news media trying to communicate most of what we didn't know in the middle of a novel virus. And that's really hard. This is where we have to have standards. Nafisa should have had like, okay, look, this is what it should be. This is how we're going to tweak it. And I'm going to ask everybody on the call to just never, ever again say, if you've seen one health department, you've seen one health department. Okay. It's a bad look. Okay. It makes no damn sense. So what we need to do is find our commonality and build together. So that again, whether I'm in the Lubbock airport or I'm in Chicago O'Hare, I have a sense that the air traffic control has some similarities.
And
Thanks,
I have
Brian.
a follow-up for this too. I totally agree of just having flashbacks for my time in Milwaukee as a health commissioner, and just the value of having a tool to be able to say, this is how many epidemiologists, this is how many lab technicians we need, so on and so forth, would have been so valuable instead of having to put a lot of energy into pleading for adequate staffing levels. Using other health departments as a measure, you normally look at cities or counties that are comparable to you in size and scope, which isn't a good model, right? Because everyone's deficient because of historic underinvestments in public health. But just acknowledging that this tool is going to be very valuable because it's going to be a big time saver is extremely important. So I wish this was available in 2018 when I was the health commissioner of Milwaukee. So thank you.
Thanks, Jeanette. And I was actually about to draw you into the conversation with one of your other hats. Having recently left the Trust for America's Health and working in the policy space, what are your thoughts on how we can kind of leverage this? I think each of you have brought up kind of education as well as advocacy. And I think those two things can be related, though they don't have to be. So when we think about advocacy and advocating for more funding, what are your thoughts on that from the policy perspective?
Sure. So I was the Director of Policy Development at the Trust for America's Health from the end of 2020 all the way up until the end of this year. So not that long, but nonetheless, we know that Trust for America's Health is a wonderful resource as far as developing reports, doing a lot of the legwork and research to understanding issues that affect public health at large. So there's an annual report that TIFA puts together that's a chronic underfunding report for public health. And that report outlines funding for the CDC, which we know is a big funder of state and local public health through pass-through mechanisms. And not every local or state official understands how this process works. So even being able to talk about that, how do you get money from the feds to the states to the locals, is something that we need to continue to educate policymakers about. Also, this whole dynamic between tax levy dollars, corporate dollars versus grant dollars versus these CDC dollars that pass through the states and locals, and HRSA, for instance, is extremely important. I can't tell you how many times I've been in meetings or I was in meetings as a local health official where there would be this assumption that, oh, well, you're getting money from HUD or you're getting money from HRSA or CDC, you can just fund the staffing that way instead of putting more corporate or tax levy dollars into public health. The Milwaukee Health Department was only 2% of the total city budget. And for years, there was this advocacy effort to try to increase funding for public health at the local level, knowing that only 2% was just a drop in the bucket. And then you wonder why you got what you got. You were underinvesting in public health. So how could you possibly have a well-functioning health department at such a low level? The other point too is just acknowledging that the power of storytelling. And as a public health official, and I started my career as an intern in public health, that sometimes we don't understand or realize that just by having the ability to articulate what we're experiencing and what we're seeing has a lot of power for moving policy and shifting policy decisions. So learning how to package your stories is something that needs to happen. Not every health department has a policy director or someone that oversees what's going on and making the connections between what's happening at the national level, the state level, and the local level. So that's another big issue in itself, is not having the right staffing resources to really make that connection for public health. And then the other point I want to make is just briefly about the pandemic and just how you have so many people now that are automatic experts in public health because they saw something on Facebook or on YouTube. And if anything, I understand that many of us would love to spend our time going back and forth with people online about public health policy and issues because we are the experts, but we just don't have the bandwidth or the time. So there's, initiatives that are out here that are really helpful that we need to increase awareness of, like the Public Health Communications Collaborative, for instance. Just a lot of resources are available nationally, but we just need to continue educating state and local public health workers, and not just the officials or the heads, but everyone, that these things exist because they can help make our jobs easier.
Thank you. And I'm going to come back to the other national initiatives, but first I want to build on something you said about kind of stories and the power of stories. And I think we hear that a lot in terms of working with elected officials. And we've talked today also about data and the need for data to make the case. So there's a comment in the chat box. It's not a question, but I'd like to ask anybody to chime in. And it's from Terry Allen in Ohio, who says, we also need to be prepared to explain the benefit of our community, or the benefit our communities will render with these additional staff in terms of capacities, scope of service, and the ultimate impact on health improvement trajectories. So when we think about this and we think about the opportunity to use not only stories, but data to educate and to advocate, just wanted to ask anybody to reflect on that.
I can go, here we've really we felt the polarization and the politicization. I think one of the most important things also for public health practitioners is don't get mad. Get mad in the privacy of your own home, but be patient in terms of the education process. My goal is to always try and connect, especially with our elected officials, their values. We all have values in some shape or form, right? Our values might be different, but I want to understand, if someone is telling me no to an epidemiologist in the middle of a pandemic, I also want to understand why you're telling me no. And justify your no. And so, but that takes time. It takes patience. It takes a willingness to keep your door open so that the individual can come and freely talk to you. And so we've gone through that process. And now, believe it or not, some of the people that were really the naysayers of public health are starting to ask me more questions and are curious about our needs, because I've been able to identify some of the key things that they value, and some not having reports or data doesn't resonate. So we use videos, we use storytelling, and some are interested in what we're doing for kids. Others are interested in what we're doing for maternal health. And so make sure that you understand the values of your stakeholders so that you can also educate and show them where you're strategically aligned.
And I can check. Oh, sorry. Go ahead, Brian.
No, please.
I think another piece I would note that where I feel like we have these challenges is conveying the complexity of the work. So for, LA County, our hiring is all centralized through the CEO and our Department of Human Resources, and they determine the classifications, they determine the pay level. And so we've really struggled in general of just getting the right person for the job. And so I think another way with the tool is really useful is it kind of speaks to the breadth of that work. Where we're seeing some inroads in the lessons learned, which again, I'll say we've been saying this from before the pandemic, is, given the polarized environment that we're in, as Nafisa has noted, is the fact of the important that we elevate those that are trusted messengers within the community. And I think it's a combined effort of public health department investments, and investments in the community infrastructure. And with community health workers, this is an avenue with which one has been really critical to our outreach and education, linking people to vaccination resources, being able to say things that's like culturally relevant and resonant to the communities that we're serving. And we're in an active space to really think about what is the real true pipeline for that work. And so it actually has created an entryway because one, folks, when they were waiting to get vaccinated, they wanted to hear from their pastor, and they wanted to hear from, the CBO where they're picking up their, their food distribution. I mean, that's where they were wanting to have this conversation. They weren't necessarily wanting to hear from a government institution. And I think that, what it does present now is that we know that there's effective strategies. I think to Brian's point, how we really talk about communication, not just as kind of just like the press releases that you do, but really what communication and public health messaging is. And two, how do we create investments that one value what has really operated in some ways as invisible and unfunded labor, if we think of CBOs more broadly, but two, where we've made these investments and how do we create pipelines that create careers within public health. So we've had community health workers and they're generally like underfunded within the department. So one, bringing the conversation of like, they've had to do a whole lot of additional work. They've become contact tracers. They've been, doing a whole host of triaging that they didn't do before. So we've tried to leverage what I think our supervisors, our elected officials have really seen as valuable resources that really serve their constituents, and then really talk about this has been really great. And so how does this really feed into the system that one creates expectations for us as a government entity to sustain, but then how do we really support that infrastructure in a meaningful way beyond just the pandemic response? Sorry to cut, Brian.
Yeah, no, I think this all builds on the idea that we need multi-sector partnerships to support public health. We are not going to be able to fix this ourselves, everybody. Let's just look at what happened in Florida, where the state health official refused to answer yes or no. Are the vaccines safe and effective? His answer was science is not a yes or no question. And then there was Missouri, where their health official wasn't confirmed because he committed the sin of being too pro-vaccine for the Missouri Senate. We will not fix this ourselves. We are beginning to see the metastases of partisanship in our actual health departments. And what we need will be the business communities, the hospital saying, yeah, my nurses and doctors were burnt out, partly because the ERs were overwhelmed because we didn't have a public health system, right? We cannot be the messengers of our own salvation. We must find other partners who will advocate for public health. And for whatever reason they believe public health is important. For some people, it'll be the value of community health. For other people, it'll be so we don't have to shut down their businesses again, or that their employees won't be unhealthy. So we have to get out of our silos. I will say forever that public health is an amazingly wonderful preacher. If you come to the church, as we all are, right? We're all public health church goers, and we love the church, and we'll sing and we'll do our thing. But then we see someone outside the church, and instead of being good missionaries, we shut the doors. We are horrific missionaries. We have to get better at that. We have to bring others into our church, or we have to go to their church and bring our message there. But we will not fix this ourselves. The partisanship is too great at this point. Our health departments and their leaders in many places are going to be not necessarily holding the values of public health. Business community, trusted community members have to hold public health accountable and be advocates for us.
This is probably the easiest panel to moderate. You're all building on one another and saying everything that's so very relevant. I want to bring us back to kind of threads that have popped up in each of your comments, which is about opportunity. So the estimate presents an opportunity. The tool presents an opportunity for individual health departments to use. Multi-sector partnerships, both from a national perspective and then at the local level, presents an opportunity. Megan, you mentioned community health workers and how they've been used in kind of new ways. So I want to talk a little bit about the silver lining here. And it's sunny here in the DC area, so my mood is bright. So let's talk about the silver lining for a bit, and let's talk about all of the opportunities. There's federal funding that is available and more that will be coming available in the public health infrastructure and workforce space. What is our opportunity? There are a number of national initiatives. Jeanette mentioned the Public Health Communications Collaborative. There's Public Health Forward in the report that was just produced. There's any number of other national initiatives that many of us are participating in. What are our opportunities? So we can do a bit of a round robin, and anyone feel free to chime in first. I just want to talk a bit about the silver lining here for a few minutes.
I can take a crack at it. I mean, it's hard to year two, but I would say that, I think that if, as history does repeat itself, which it often does, is that we've seen after the HIV/AIDS epidemic, we saw after the Ebola scare, that there was kind of this ongoing pipeline of funding for some of these efforts. And I think that this is the moment is now for us to really be able to leverage these funds. I would say where we've seen opportunity and have been able to capitalize has been through the federal public health infrastructure grants, particularly the disease investigation grant, and the one that went through the crisis cooperative agreement, which is an emergency preparedness fund. And we were able to actually leverage the staffing up report to bring to the CEO about, the need to realign and to rethink this work. And we've identified, a set of core areas that we needed to build out. Our data informatics, we were working on very broken systems with very high volume cases, particularly in a place like LA, high value systems that we needed to invest in, educate schools. We had to work, obviously there's a lot of focus on schools today, and there's always been focus on schools throughout this entire pandemic. And what does it mean to really build out meaningful relationships? Elected officials that didn't pay us any attention. We have 88, different, jurisdictions across our county that all of a sudden want to know what public health does and what our role is in there. So we've identified, in communications, I'd also elevate, or areas that we knew that we needed to invest in more. And we've been able to position that to actually push for permanent positions, not at the scale that we've had, but being able to say that our lessons learned, and we're seeing the work here. We also leverage Trust for America's Health's report on also understanding. So shout out to Jeanette's team around kind of the cost per person and population to really, move that discussion forward. And so using those, 2 to 5 year grants to be able to sustain what our core operations are, a unique opportunity. The state, dollars from California, and I see that there's some threads there, which we'll see what the 200 local allocations will look like for LA. And then, if Congress can get Build Back Better, it can get that legislation in too, is really to be able to leverage those as opportunities that have really served to benefit us as moments to be able to get more permanent items and core deficits in our department. And we hope that that'll be a continued conversation at the local level here.
Thanks, Megan. Does anyone want to build on Megan's comments or share a different perspective? Jeanette?
Sure. So just acknowledging that we tend to be overachievers in public health. Like, we don't want to ask for help. We don't know how to ask for help sometimes. So, like getting out of that mentality of, duct tape, we're going to do it, because we're so passionate and care about the communities that we serve. We have to work with others to be able to do that. And the notes about, working with community organizations, helping maybe individuals like kind of get to the point of receiving funding so that they can help their communities. If we get out of the way and just provide the resources, community can handle their own problems and solve their own problems. So how, as a public health department, how do we facilitate that process? You look at your community health assessment, your community health improvement plan, and really doing things differently, not just looking at a disease model, but looking more at systems and policy on how to increase the quality of life for residents in your given community is extremely important. And then just a note, kind of reflecting to like reorganizing a health department. Of course, during the pandemic, there was like some unofficial or de facto restructuring because people had to be shifted to emergency response or incident command. But just using that flexibility to, move away from a traditional siloed model of public health and creating some opportunities for those that may have interests in other areas within a health department that may give them a renewed interest in staying in the public health profession. I mentioned lab earlier, not every health department has a lab, but you might have individuals that have interest in working in the lab, or people that might be interested in food inspection or epidemiology, whatever the case may be. But that takes assessment and listening to your staff and being able to support them moving into different roles in job sharing and shifting within health departments. So I just note those as some loose examples of ways to kind of rejuvenate interest in staying in public health, renewed commitment in public health. And then of course, myself as an example, I'm an independent consultant now. Being able to support health departments and groups from the outside is very rewarding. So just knowing and keeping connections with individuals that may have retired or moved out of public health to really bolster some of the activities of public health that you may not be able to do because of the politics in your environment is another way to create like a workaround to move things forward. So just being very savvy about how you're able to move things forward. It doesn't have to have your name tied to it. Sometimes that's an ego check for us. But just doing things and being strategic, going through as far as like night moves or stealth mode to get things done is really helpful right now during this pandemic.
I love that stealth mode.
Yeah.
And bringing it back to the community. I think that's so true. And that's why we're all here. I think we can be our own worst enemies with our passion, right? So we do more for less, and then we're expected to do more for less. And it becomes kind of this perpetual cycle. But that's why people are in public health. Other thoughts on this?
So for us, a little bit, it's different because we're a smaller health department, and a lot of our funding comes from the state. I've taken more of Brian's approach in really building local partnerships because I think for us, it's so important that we remember how local investment in public health is also critical in sustainability. So when we have individuals talk about like taxpayers' dollars, my message is that, well, I will show the taxpayers how public health is so important, and this is how we're investing back into the community. And so next week, for example, we will have a mailer that will go out to 66,000 households here in Black Hawk County, explaining public health, our services, and also vaccinations, right? So it was so important for us to not just send out communication about COVID-19 vaccines, but what else do we offer to the community? And so that's been very helpful. The second thing is with the Tyson outbreak, I think our business community was really on edge. Like, is public health going to go against the business community? And I was very assertive in not allowing that narrative so that the business community also felt, okay, when we have a problem, we can go to public health and they can support us. And so that has really solidified our relationship with the business community. So they understand that we are here to educate you first. We are here to support you first. And so we've had businesses now that are interested in what we do, discussing ways in which they can support our initiatives. And so that's exciting. I think it's just important for us to maintain that balance, and push back on that narrative that is, politicizing us and really creating that division. Because at the end of the day, I think for us, if we're very intentional about, health equity, we have to work on all the different factors that, influence or have an impact on population health outcomes. And that's the diverse sectors that we work with on a day-to-day basis.
So you've all mentioned either explicitly or implied a number of different skills. I think that we're not taught in public health school, and we know that many public health workers come from outside of traditional public health training. I don't think there's a class on stealth mode. Megan, you mentioned a number of rising stars that have been realized through reassignments. You mentioned that in the chat box. And then Nafisa, you just talked about an entire strategy with the business community. And I'm sure no one was taught any of those things in an explicit way. So how do we grow the next generation of public health workers to be able to have the right skills, the strategic skills that they need to do the work? So we're always going to need epidemiologists, and that's a technical skill, but there's this whole suite of soft skills or strategic skills that are needed really to be able to advance this work. Brian, I wonder if you might have a thought on strategic skills that governmental public health workers might need.
Yeah, I mean, it is going to have to be a difference in how we train our public health staff. I mean, we are brilliant scientists, excellent health educators, but we need, if you think of that as the kind of, vertical line. We need that horizontal line of communication and problem solving and change management. And that's just, it's not getting taught. And so again, our disjointedness in public health extends to our education as well, right? I don't really have a silver lining when it comes to where we are in public health. I'm watching partisanship go deep into our health departments. I'm watching legislators say things like Medicaid expansion just doesn't work. And I'm watching us not be unified in our responses. Public health is the best living example of the Tower of Babel, where maybe at one point we were all working together, and so the Lord struck us down and made us all speak differently and not be able to work together. This is what we have to do. We have to find our common language, our common voice through our advocacy organizations. Because if we don't find a way to better communicate to everyone what public health does, how important it is, and if we're not training the right people, then we will not have additional success. And maybe they don't come out of schools of public health. Maybe they come from a whole pantheon of other schools. But it's also challenging to watch us fight amongst ourselves. I am a super big Twitter geek, and I have watched and participated in a debate over the last week with luminaries in public health. One's group saying, let's get rid of all the COVID mitigation strategies, and the other saying, no, we can't do that yet. That's within our own house. And again, we need to find our singular voice, and part of that is educating our workforce both in place and in school. But it needs to be much more thoughtful. We offer so much training in public health, but I don't know that we've stepped back to ask if it was the right training.
Thanks, Brian. We have just a few minutes left. I'm going to turn to our other three panelists for just your final kind of thought, and I'll give you each just 1 minute. Jeanette, I saw you come off of mute first, so we'll go Jeanette and then Megan and then Nafisa. Just 1 minute each on kind of anything you'd like to close with for today.
Absolutely. Thanks for having me again. So just something that Brian said just resonated with me about our training in public health. So Milwaukee County and City was the first in the country to declare racism as a public health crisis. So we know a lot of places were doing that, and mainly because of seeing what was happening in our country in 2020 with the social justice movements and just the pandemic, amplifying inequities. But when we're looking at the mismatch of actions versus policy, where we're like, racism is a public health crisis, but everything's open, knowing who's the essential workers, who's being most impacted. It just really like waters down or just negates the whole purpose of even making those declarations. So getting public health professionals to understand that your actions matter. And yes, as a public health professional, you are an individual, you are a person, but whoever you work for, you also represent their views as well. So is there a mismatch between what they're saying and doing versus what you're feeling? Then maybe you need to evaluate where you're working. But just that point of getting us to understand how our decisions save lives or harm lives is extremely important. And I agree with moving outside of just the public health silos and looking at other professions as ways for us to move forward together. I mean, we have some brilliant individuals that don't have formal public health training, and we have some that have the Ivy League training that are, saying things that are totally contrary to public health and ethics. So how are we speaking on behalf of those that are most vulnerable? So it's just something that I think about very often, and just, again, challenging and more so calling people in versus out. But when they're not listening to being called in, then there needs to be a call out on some of these individuals that are perpetuating harm. So on a bright note, though, I'm very happy that we have this staffing up initiative and this resource, as this is the time to be able to answer the question of how many people do you need and by type, so that we can quickly fill these positions. It's budget season's coming up and all of that. So it's perfect timing to be able to have this resource to answer those very, very critical questions. Thank you.
Thank you. Megan?
Yeah, I'll just to comment, I came to public health as a community organizer. I didn't think I was going to be a public health person. I was doing environmental justice work and healthcare access work and really wanted to really transform the system that I feel like marginalized so many folks. And knowing that the design that we're seeing within the pandemic, the inequities, the loss of life on the backs and the burdens of Black, Brown, Indigenous people is by design. And this is the opportunity to unveil that. And so I think that, to this point about the skill set, I think that as an organizer, you learn to manage up across. You learn how to pivot your communication to like the audience, right? I'm not going to sell you on racial justice, but I will sell you on the numbers in your community and who's getting impacted. And I'm going to work with those constituents on your side, in your district, to be able to move that work forward. And so I think that we are at a critical time. I think that the Staffing Up tool provides an opportunity to really move the conversation forward that could be potentially, again, Congress get it together, aligned with federal investments to sustain this work. And I think there's ways to engage in public health, as we learned with COVID, not just in the health departments, but the entire fabrics of our community. And how do we collectivize? Because we want healthy, thriving communities. We want people to be beyond the level of surviving, but really to be able to have, what they need to do their best. And so I think it's how do we kind of cut those angles and continue that conversation? But we have a tough road ahead. I would say I have all the same concerns that Brian does. And so how do we have a unified front around how data can really move this conversation forward, and how do we work in partnership across all the things in the context that makes our communities what they are to really advance the shared mission for health and well-being.
Thanks, Megan. Nafisa, final thought.
Thank you. And Jeanette and Megan really said it very well. My last message is that don't lose hope. Don't lose hope, and bring public health to the people you're serving. And ensure that they're part of the decision-making process and their voice matter. Empower, be part of the empowerment process, And so I've just been so grateful to our community, because in moments where I couldn't speak, they did for me. And so I think that's also something important to know, is really bring back public health to the community and the people that you are serving. Thank you.
Thank you. And thank you all so much. You summed it up perfectly. We covered a lot in this hour. I know we barely scratched the surface. The chat's been fantastic. There's obviously a lot of interest in this. So I thank you all for joining us today. A huge thanks from us at PHAB and PHNCI to the Beaumont Foundation, CDC Stilts, JP and his team, the University of Washington, everyone who partners together to make Staffing Up happen. We hope the estimate is useful. We look forward to the calculator being useful when it comes out later this year over the summer. And just thank you all. And, please continue to engage in this conversation through Twitter, through all the channels, and we'll see you all next time. Thank you so much. Have a good one.